Hello, everyone. Welcome again to our MDM Sunset session, reflecting on the risk element with Q&A activity webinar. My name is Ashley Decoto, and I am a specialist with our provider outreach and education team. On the call with me today is my friend and colleague, Leanne Foster, who will be helping out with the chat. I have just a few reminders for everyone before we get started. This webinar is part 2 of our 2-part series on the risk element of medical decision-making for evaluation and management services. Yesterday, Leanne held the part 1 webinar, which provided more of a comprehensive overview on the risk element. Now, if you were not able to attend that session yesterday, that recording will be available within the next week or so in the training center on our website and also on our YouTube channel. We'll also have a recording of this session available in the training center on our website, and Leanne will be adding a link for the training center to the chat. It will be available out there on our website for the next 60 to 90 days, barring any technical issues with the recording. And you can access this here without having to access YouTube, as we do recognize that not everyone is able to access YouTube at work. The recording will also be available on our YouTube channel, and it will stay out there as long as this information remains relevant and current. I do want to note that a copy of the presentation will be emailed to all attendees following today's event. We will be taking questions through the chat today, which again, Leanne will be monitoring, and I will check in with Leanne at the end of the presentation, time permitting, for any unanswered questions in the chat. We did have quite a few questions that were pre-submitted with registration, and I will be answering those that relate to the risk element of MDM throughout the presentation today. If we do not get to live chat questions, we will answer those in a follow-up email. Okay, for our agenda, we're going to start off by doing a brief recap from Leanne's Part 1 webinar yesterday. After that Part 1 recap, most of our session will be the interactive Q&A activity. And then lastly, we will share a few resources. Again, this 2-part series is meant to focus specifically on the risk element of medical decision-making. While we will be talking about the risk element today, we did have a handful of questions regarding the problem and data elements of medical decision-making, which we're not covering in this session today. The recordings from the series on the problem and data elements are out on our YouTube channel. All right, let's get started with a recap of Leanne's session from yesterday. So when you're choosing your code for most evaluation and management services, you can use either time spent for that encounter or medical decision-making. When you're using medical decision-making, or MDM, to choose your level of service, you'll need to consider 3 elements. The first element is the number and complexity of problems addressed during the encounter, which Leanne and I talked about in a series back in June. The second element of medical decision-making is the amount and complexity of data reviewed for the encounter, and we did that series last month in July. And then the third element is our primary focus for today, which is the risk of complications and/or morbidity or mortality of patient management. Most E&M services have 4 levels of service, which are straightforward, low, moderate, and high, or some just have 3 levels where straightforward and low are combined into one code. You will select your level of service based on meeting or exceeding the requirements of that level for 2 out of the 3 MDM elements. So for example, if you have a moderate level of problem, moderate level of risk, and low data, you can select a moderate level of service because you met that for 2 elements. Another thing that's really important in medical decision-making is using the CPT definitions for each element. And these are outlined in the CPT book and also in a CPT resource that Leanne will be putting in the chat. There are definitions there for the types of problems, the components of the data element, and for the examples of risk. So what is the risk element of medical decision-making? Risk for medical decision-making refers to the risk of complications and/or morbidity or mortality of patient management. And CPT defines risk as the probability or consequences of an event. So this is looking at the likely outcome based on the treatment decisions that are made for an encounter. This could include both the decision to initiate treatment, and it can also include the decision to forego further treatment. So maybe your practitioner is considering prescribing a certain medication and ultimately decides not to prescribe it after discussing possible side effects with the patient. In those cases where a decision is made to forego treatment, what are the risks of morbidity or mortality for the patient based on that decision? We had a pre-submitted question along those lines, which said, if a provider documents that a patient cannot take NSAIDs due to CKD or another condition, can they be considered prescription drug management, which we will talk about in more detail later in the presentation. But there can absolutely be cases where the risk identified involves a situation when there were treatment options considered and then not chosen after discussing options with the patient, including prescription drug management. So for the scenario presented in this question, what are the risks to the patient based on the provider choosing not to prescribe or even suggest over-the-counter NSAIDs? That's the key with this type of situation. There's a thought process involved for the practitioner in weighing the possible treatment options. They elected not to go with NSAIDs, so what are the risks to the patient from that treatment decision? While CPT gives prescription drug management as an example of moderate risk, there does really need to be documentation of what the risks are from the decision to prescribe, or in this case, not to prescribe a medication. The risk element, excuse me for just a moment, I have a tickle in my throat. So the risk element is really important for your practitioners to document. You really don't want to make assumptions on the risk level. While CPT, again, provides examples for risk, these are just examples. Practitioners need to document the risk based on their clinical judgment. The CPT book says that physicians apply common language usage meanings to terms such as high, medium, low, or minimal. So if the documentation is not clear on the risk, you may choose to seek clarification from the physician. Using these terms like high, medium, low, along with the identified risk factors, can help take some of the subjectivity or some of the guesswork out of the equation for a reviewer and helps make it more clear what the level of risk is based on the practitioner's thought process and clinical judgment. So we will be talking through the examples CPT gives for risk during our Q&A activity, but again, keep in mind that these are just examples. The AMA has even shared that they added so few examples because the level of risk will be specific to each patient and decisions made for that encounter. So documentation will need to support the level of risk by showing what the risk is for the management of that patient's condition. This will be based on the physician or practitioner's thought process and assessment of the level of risk based on their treatment plan. So we included this slide here to show what errors have been found that relate to selecting level of service. So we have two of the top CERT errors for office visits listed here. The first error listed here, you might have seen this one before, which is the error for documentation supporting a lower level of E&M. So make sure that your documentation supports the level of service billed. Remember, for the risk element, documentation needs to support the level of risk. This needs to be identified by the practitioner, and there should be justification as to why they've deemed the patient to be a moderate risk, for example. The second bullet here, this might come as a surprise to some, which is the error for documentation supporting a higher level of E&M. And the point we want to make here is don't sell yourself short for work that was done. So if the documentation does support a higher level of risk, be sure to give credit for that. Or if maybe you have a low level of risk, but documentation supports a moderate level for the problem and data element, make sure that you build a moderate level since you've met that for 2 out of the 3 elements. We did include 2 links here. The first is to a page on our WPS website with more information on E&M CERT errors. And then the second link takes you out to the CMS website where you can find a list of CERT reports, including this report from January of this year. Okay, now we're going to get ready for the interactive Q&A activity. We designed this to be kind of a fun way to test your knowledge on the risk element. So what we'll do is launch a poll for each question during this activity. And even if you aren't 100% sure on the correct answer, we'd love for you to go ahead and participate and give it your best shot. I'll give you a moment to lock in your answers, and then I'll walk through the correct answer for each question. Now, in case you're new to these Q&A activities, I want to explain how to use our webinar software for the activity. We will be using Slido within WebEx to launch each question. To find Slido, you'll need to click on an icon with a plus sign. It should be down next to the chat icon towards the lower right of your screen, and it should say Show Apps or Show Apps Panel if you hover over it. Once you click on that button, it should allow for you to click on Slido, which again is the platform we'll use to launch these questions. Before I launch our first question, we did have some questions asking for resources, and this slide has resources for the activity today, and Leanne will also be placing links for each of these into the chat. And you're welcome to have these open to help out with our activity. The last resource listed here is the CPT page I mentioned earlier, and this is one that I find particularly helpful for medical decision making. This is really great too for anyone that doesn't have access to a CPT book. So in this resource, you'll find the MDM chart beginning on page 8. So again, feel free to open that up to help you with the questions during this activity. All right, for our first question, there really is no right or wrong answer for this one. We just want to get a feel for what our attendees think about the MDM elements and give everyone a chance to find the Slido app in case you haven't found that yet within WebEx. So the question is, which element of MDM do you personally find most challenging? You can select A for problem, B for data, C for risk, or D if maybe you don't know or if all of them are challenging. All right, that's kind of what we expected. So far, it looks like about 75% of you are saying risk. So for those of you who did select the risk element, we hope that this series will help some with that challenge. For those who selected problem or data, make sure you check out the recordings from each of the series that we did for those 2 elements, for problem and for data. Okay, now let's really get into the questions, and we'll start out a little on the easier side. Okay, so for our first question, which of the following describes the risk element according to CPT guidelines? And you can select all that apply. Is it A, based on consequences of problems addressed? B, does not need to be documented by the practitioner? C, based on thought process of the practitioner? Or D, may use common language such as high, medium, low, or minimal? I'm going to give it just another minute. I see a few are still getting their answers in. Okay, so the answer for this one is A, C, and D. Let's look at each of these correct answers. So when we look at the CPT definition of risk, we'll find each of these three answers. First, for A, we see that for the purpose of MDM, level of risk is based upon consequences of the problems addressed at the encounter when appropriately treated. So the level of risk will be directly tied to the outcome based on how the problem addressed is treated during the encounter. Next, for C, the definition of risk is based on usual behavior and thought process of a physician or other qualified healthcare professional. So based on their clinical judgment, what is the expected outcome of the treatment decisions that they made? For answer B, and I touched on this a bit during the part 1 review, the CPT definition again calls out that clinicians can use common language, such as high, medium, or low. And this kind of ties into why answer B is not correct. There must be documentation of what the identified risk factors are. So they might document that the patient is at risk for heart failure. But what they can also do is assign a level to the risk based on their judgment as a practitioner. So maybe they know that there's a high risk based on the patient's health status, or maybe just a low risk. Again, we know this can be subjective, but it's ultimately the responsibility of the practitioner to assess and document the risk. And using common language like CPT suggests can help make it a little more clear. All right, we'll move on now to the next question. For our next question, which of the following describe morbidity according to CPT guidelines for MDM? And you can select all that apply. Is it A, state of illness or functional impairment? B, expected to be of substantial duration? C, function is limited? Or D, risk of death? Okay, the answer is A, B, and C. So for our risk element, we're looking at the risk of either mortality or morbidity. Mortality is the risk of death. Morbidity, on the other hand, is a state of illness or functional impairment that is expected to be of substantial duration, during which function is limited, quality of life is impaired, or there is organ damage that may not be transient despite treatment. So what significant impact is this treatment going to have on the patient's health and well-being? That's where documenting the risk of morbidity comes into play. We had a question asking for an explanation of high risk of mortality. High risk of mortality under the risk element is about the high stakes from the treatment plan, not just how sick the patient looks. So when looking at the treatment being considered during an encounter, ask, does that treatment result in the possibility of death or permanent life-altering disability if something goes wrong or if the condition is left untreated? And this doesn't necessarily mean there's a guaranteed catastrophe as a result of treatment. The CPT book also tells us that the assessment of the level of risk is affected by the nature of the event under consideration. And they give the example that a low probability of death may be high risk, whereas a high chance of a minor self-limited adverse effect may be low risk. So the severity or nature of that risk factor factor is key here. That's why it's important for your physicians to document what the risk level is based on their clinical judgment. Is the patient at high risk for death or some type of adverse outcome based on these treatment decisions? In other words, what is the consequence or what is likely to be the outcome of proceeding with the treatment decisions made during the encounter? Sarah asked a question, which was, can a provider put in the documentation, patient is moderate risk of XYZ? Is this acceptable? And this is a great question, and the answer is yes. This is a good practice, and even CPT guidelines suggest that practitioners document the risk level using terms like medium or high risk, for example. So it is up to the practitioner to determine the level of risk, and they can absolutely document that a patient is moderate risk or whatever the risk level is. But the documentation should support why. What are the specific risks to that patient based on the decisions made for that encounter? All right, moving on to our question for slide 12. So for this question, who is responsible for determining the level of risk? Is it A, coders and billers, B, practitioners, C, patients, or you can select D if it's Leanne? All right, everyone got their answers in super fast for that one. The answer here is B. This is really, again, key for the risk element. The practitioner is responsible for identifying what the risks are associated with the treatment plan, and they can describe it as high or low risk, for example. Now, CPT does say that quantification is not required, meaning they do not need to assign a number to it, such as saying they're at 75% risk of mild headaches or 1% chance of brain damage, but the risk must be identified. We were asked several questions about specific tests ordered or treatment decisions made during an encounter and asking what the risk level is. One question asked if we consider the administration of CT IV scan contrast as high. Another question asked if managing IV drip meds can support high risk. So these are just a couple, but again, we had several questions like this. And the answer is the same. It will depend on what your documentation supports. Has the practitioner documented their assessment of the risk level? Are the patient-specific risk factors documented and support the practitioner's assessment of the level of risk? The information documented in the record is what will determine the level of risk for medical decision-making. Remember that CPT gives examples. Think of these examples as kind of how the situation would typically be classified, but each encounter will really depend on the practitioner's assessment based on their treatment decisions for that specific patient and their clinical judgment using what they know about the health status of that patient. We were asked another question kind of along these same lines, which asked, what would be considered low risk? Well, ultimately, risk, again, is driven by the practitioner's clinical management and must be supported by information documented in the medical record. If the practitioner feels that based on his or her treatment decisions, there's a low risk of complications or morbidity or mortality, that would need to be documented. For example, maybe my practitioner suggests rest in ice for the pain I'm having, yet again in my knee, a treatment decision that my physician would probably consider low risk. CPT says that the assessment of risk, again, is affected by the nature of the event under consideration, meaning even though my doctor knows there's a good probability I'll continue to have some pain and stiffness, she documents it at low risk because of the minor severity of the outcome that she anticipates. All right, on to our next question. So our next question is, the risk element may include possible management options considered, but not selected after shared decision making. True or false? So the answer for this one is true. You may have situations where a physician has considered certain treatment options and, after discussing it with the patient, decides not to proceed with that treatment or opts for a different treatment. If that discussion and consideration is documented, it can factor into the risk element. An example of this could be maybe contemplating hospitalization, but deciding on an alternative level of care. So maybe you have a patient with advanced dementia who has an acute condition that would typically warrant inpatient care, but after consideration, the patient and their family declines inpatient care as their ultimate goal is comfort with palliative treatment. All right, on to our next question. So for the next question, risk level for minor or major surgery is based on the global surgery period. True or false? All right, it looks like most of you have your answers in. The answer for this one is false. The risk level is specific to each patient for that particular surgery and is based on the practitioner's clinical judgment. So a surgery that is minor for one patient may not be so minor for another patient. For example, maybe an otherwise healthy 30-year-old patient is having a gallbladder removal, and the physician considers this to be a minor surgery for that patient. But for an 81-year-old patient with COPD, this might be considered a major surgery because of the risk for that specific patient. CPT gives decision regarding emergency major surgery as an example for high risk. So that's where we have to consider a few things. First, major versus minor surgery is not based on the global surgery period. Rather, it's based on how the practitioner would classify that surgery, meaning is it minor or major for this particular patient. The other thing to consider is whether or not it is high risk for that patient, and did the practitioner document what those risks are. Just because the patient is having an emergency surgery does not automatically give you high risk without documentation of the practitioner's thought process and their assessment on the level of risk for that patient. We had a question which asked for details specifically on decision regarding minor surgery with versus without identified risk. So for moderate risk, CPT gives the example of decision regarding minor surgery with identified patient or procedure risk factors. What this means is you have a practitioner who has made the decision that surgery is needed, one that would typically be considered a minor procedure. But for this particular patient, the practitioner has identified that there are certain risks that are not usually associated with that minor procedure. I'll give an example. Let's say a physician has decided to perform an incision and drainage of an infected cyst on an otherwise healthy 25-year-old. So in this case, we have no identified risk factors. But let's say a physician made the decision to perform that same procedure on a patient who is immunocompromised due to active chemotherapy, putting the patient at risk due to their compromised immune system that would be unable to fight off bacteria should the infection spread. That would be an identified risk for a procedure that would otherwise be considered minor. There's a risk that is specific to that patient, in this particular example, due to a compromised immune system. All right, on to the next question on slide 15. So for this question, a surgery with a 90-day global period automatically counts as high-level risk for MDM, true or false? All right, 100% of you got that one correct. So the answer is false. This is along the same lines as what we talked about for the last question. Just because a surgery has a 90-day global period does not make it a major surgery for every patient for the purpose of medical decision making. The difference between minor and major, again, will be determined by the practitioner. So if the patient is having an elective surgery with a 90-day global period, what are the risks associated with making that decision for surgery? Those risks would need to be documented. All right, for the next question. So this question is, which of the following are true for both elective and emergency surgery for MDM risk? And you can select all that apply. Is it A, maybe a minor procedure, B, performed immediately or with minimal delay, C, planned in advance, or D, may be a major procedure? All right, looks like most have their answers in, and we're a little bit split down the middle on this one. So the answer for this one is A and D. In the definitions for medical decision making, CPT outlines the difference between elective and emergency surgery. Both elective and emergent or urgent procedures describe the timing of a procedure. An elective procedure is planned in advance, and an emergent or emergency procedure is performed immediately or with minimal delay for patient stabilization. Both elective and emergent can be either minor or major procedures. We had a question which asked if a procedure performed at the same visit as the E&M counts towards the risk element. So it can count, but it will depend on what the documentation supports. CPT gives the example for high risk of decision regarding emergency major surgery. So is this same day surgery something that was decided on today to perform as an emergency surgery? What are the risks to the patient based on the practitioner's decision for that patient to have the procedure done today? Or was this an elective procedure that was scheduled in advance? If so, what are the risk factors that have been identified specifically for that patient in having this surgery? And those risks would apply for the encounter in which the physician decided that the patient will need the surgery. So yes, there may be risks in situations where a procedure is performed the same day as your E&M, but those risks need to be documented if you are counting the risk towards medical decision making. These are the risks based on the practitioner's decision for the patient to have that surgery. I apologize, I'm having a little bit of a delay on the slides. There we go. Slido was a little bit delayed too. Okay, here we go for our next question. Evidence-based risk calculators are not permitted for assessing patient and procedure risk. True or false? All right, I'm getting a kick out of 4% of you selected answer D. Is it Friday yet? So the answer for this one is false. CPT allows for use of evidence-based risk calculators to help assess patient and procedure risk. So if you're using some type of surgical risk calculator in your practice, for example, that is acceptable, but it's not required. Clinical judgment and documentation from the practitioner are still needed to support the level of risk. One question asked if there are evidence-based calculators recommended by WPS or CMS, and no, we do not have any preferred or recommended tools or calculators for risk. You're welcome to use them, but again, they're not required. All right, next question. So for our next question, which of the following are true about prescription drug management? And you can select all that apply from these options. Is it A, over-the-counter drugs may be included? B, always moderate risk? C, physician must assess and document risk level? Or D, a note that medication list was reviewed is sufficient? I'm going to give it just another moment on this one. A few are still getting their answers in. All right, the answer for this one is A and C. So over-the-counter drugs may be included in this, but the risk of that drug would need to be documented. Prescription drug management is not always a moderate risk. The CPT book lists prescription drug management as an example under moderate risk, but that's the key here. It's an example. The practitioner must document the risk of the drug for that patient. Just making note that the medication list was reviewed does not automatically give you moderate risk. So look for information in the documentation on potential side effects, interactions with other drugs. There may be impact to or impact from comorbidities. Again, the risks should be documented. We had a pre-submitted question about prescription drug management, which asked, if the provider documents that they discussed over-the-counter drugs to take, including alternating Tylenol and Advil, but no dosage or instructions, can we still credit that? And the answer to that is probably not. If there's no documented risk from taking those over-the-counter drugs, then that really does not count. For a healthy patient, there may be little or even no risk for taking over-the-counter NSAIDs. But for some patients, these may be risky, and that needs to be documented as to why there is that risk. CPT provides some clarification on this in a Q&A, and I've asked Leanne to place a link for that Q&A in the chat. But what this Q&A says is there is no blanket guidance for services to represent specific levels of risk. The physician is responsible for assessing and documenting the level of risk of the services to be performed, including medicine management, prescription, or over-the-counter, based on a specific patient's risk factors and risks typically seen with the drug. So this means that the physician must determine the risk associated with their treatment decisions, or in the case of prescription drug management, what is the risk based on prescribing or maintaining that drug? Another question asked, does stating continue meds in documentation equate to prescription drug management? So if the only thing documented is to continue the medication, that does not give us moderate risk. The risk, again, needs to be documented. If there are certain risks to the patient by continuing that medication, we should see that in the documentation. If it's not clear, you'll want to seek clarification from the practitioner. It's really important for practitioners to document the risk. Keep in mind that even though prescription drug management is given as an example of moderate risk, risk is the element that even the CPT book specifically says must be documented by the practitioner. We had another question which asked if the prescribing provider is the only one that gets medication management credit. And the answer to that is really yes. Medication management or prescription drug management accounts for the risk associated with treatment decisions. So the prescribing provider is the one deciding that the patient needs to be on a certain medication, and the risk associated with that decision is reflected in the risk element of medical decision making. All right, we have a few questions left. We'll get into our next one. For slide 19, there we go. Okay, for this question, suggesting a patient go to the ER counts as decision for hospitalization and is automatically high risk. True or false? All right, I think I made that one a little too easy. The answer here is false. 100% of you got that one right. If the primary care physician tells their patient to go to the emergency room and the ER physician then makes the decision to admit them, the primary care physician did not make the decision and would not count it as such. Remember, the physician who makes that decision is who would count it, and the risk level should be documented. So if they're referring the patient to the ER for further evaluation, what are the risks associated with that decision, if any? For high risk, CPT lists decision to hospitalize as an example. While this is an example of high risk, the documentation should still show what the risks are for that patient. What is the practitioner's thought process? What are the risks for the patient or potential adverse outcomes? Or you might have situations where the decision is made not to hospitalize a patient. In either case, the risk associated with that decision should be documented. For example, maybe you have a physician who decides to hospitalize a patient presenting with an acute pulmonary embolism and documents a high risk of life-threatening bleeding complications from initiating immediate inpatient IV heparin therapy. The decision to admit the patient weighs this treatment risk against the patient's immediate risk of fatal cardiac arrest at home. We had a couple questions about directing the patient to go to the ER. One asked if an urgent care provider or a primary care physician decides to direct a patient to the emergency department for further evaluation, what is the risk level? So the risk, if you guessed it, would need to be documented. Transferring the patient to the emergency room is not really considered a decision regarding hospitalization, so it doesn't necessarily fall under that example of high risk unless the documentation supports that based on these treatment decisions, the patient is at high risk of morbidity or mortality. One of these questions also asked about moderate risk in these situations. And you'll want to look at what the documentation shows. Is there a moderate level of risk to the patient based on the decisions made by that urgent care provider? What are those risks? That information needs to be documented to make it clear to a reviewer. All right. Our next question. Which of the following describe social determinants of health for MDM risk? Select all that apply from these options. Is it A, a CPT example of high risk? B, economic conditions influencing health? C, impacts decision-making for the encounter? Or D, may include food or housing insecurity? All right, the answer for this one is B, C, and D. CPT gives the example for moderate risk of diagnosis or treatment significantly limited by social determinants of health. This includes economic and social conditions that influence the patient's health. And examples of this could include food or housing insecurity. So whatever the social determinant of health is, you'll want to make sure that's documented along with how it affects the patient's treatment. One example could be a diabetic patient who does not have electricity. Well, the physician has to consider this in deciding on treatment and decides against prescribing insulin as this patient has no way to refrigerate it. There are risks in that treatment decision, which was impacted by a social determinant of health, and those risks would need to be documented. Or maybe you have a patient who is homeless and does not have access to clean water, let's say. And this compromises their ability to perform daily wound care and keeping the surgical site clean. This creates risk of infection that the practitioner has to consider when they're making treatment decisions. Okay, we have just a couple of questions left. Boy, Slido does not want to cooperate. There we go. Okay, for this question, we have kind of a scenario. Cody Coder reviews documentation and sees that Dr. Kim documents moderate risk for falls resulting in injury for Betty. Cody disagrees with the risk assessment. What action should Cody take? Is it A, ask Betty which code to use, B, count it as high risk, C, call Betty to see how she's feeling, or D, ask Dr. Kim for clarification on the level of risk? All right, as you all know, the answer is D. 100% of you got that one. Ask Dr. Kim for clarification. So maybe Cody Coder knows that Betty is an older patient with osteoporosis and thinks that Dr. Kim's note does not accurately reflect the risk level for Betty. Cody, of course, cannot just make assumptions and decide to assign this as high risk. Now, he may get input from Dr. Kim, and Dr. Kim can provide clarification on her assessment of Betty's risk. But any clarification would need to be documented to support the level of risk assigned for medical decision making. Again, I know all of you got this one right, but we want to point out how important it is for physicians to show their assessment of the level of risk and provide details of what those risks are. Jennifer pre-submitted a question with registration, which asked, does high risk for falling count as high risk since falls are known to cause so many types of injuries? And this is a fantastic question. And this really ties into what we're talking about for this slide. And I think it's important to talk about here. So the risk level for MDM does depend on the severity of that risk. This is like that example that CPT gives where a low probability of death might be high risk, but a high chance of a minor adverse effect could be considered low risk. So the physician really needs to weigh in on their assessment of the patient's risk of complications or morbidity or mortality. So if in our scenario here for this question, we were to plug in my name instead of Betty, well, I'm at a high risk for falls because I'm so clumsy, but I don't have osteoporosis or any comorbidities that would escalate my risk level for MDM. So my physician could document my chance of falling, though I don't know that she would, because there's really not a big risk of morbidity or complications based on her treatment decisions that relate to that. But if Dr. Kim has just prescribed something for Betty, knows it can make her dizzy, and wants her to take it easy because she also has osteoporosis, that risk of falls becomes a much bigger deal and a higher risk for Betty. So have those conversations with the practitioner. Is Betty high risk based on the treatment decisions or management of Betty's condition, or are they clumsy, but that clumsiness is not a major concern, and we have minimal or no risk even of morbidity or mortality? All right, for the last question, I can get this one to launch. There we go. So for the last question, which of the following describe drug therapy requiring intensive monitoring for toxicity? And you can select all that apply from these options. Is it A, CPT example of high risk, B, primarily for assessment of therapeutic efficacy, C, assessment for adverse effects, or D, a drug with potential to cause serious morbidity or death? All right, the answer here is A, C, and D. So drug therapy requiring intensive monitoring for toxicity is an example that CPT gives as high risk. This is a drug that requires intensive monitoring because that drug has the potential to cause serious morbidity or death. This does not include monitoring just to assess the therapeutic efficacy, meaning it does not include checking to see if the drug is helping the problem it was prescribed to treat. CPT gives the example of monitoring glucose levels, which does not meet this definition, as the primary purpose is to check the therapeutic effect of the insulin. The intensive monitoring is assessing for adverse effects. This can be on a short-term basis, or it can be on a long-term basis, as long as that monitoring is done at least on a quarterly basis. The example that CPT gives that does meet this definition is monitoring for cytopenia in the use of an anti-neoplastic agent between dose cycles, which is monitoring for adverse effects rather than checking to see if the drug is working properly. Now, monitoring can be done with a lab test, physiologic test, or imaging. The other requirement for drug therapy requiring intensive monitoring is that the monitoring needs to affect the medical decision-making for the encounter. So how has the monitoring affected treatment decisions that were made for that encounter? That information would need to be documented. We had a pre-submitted question asking, what are the key indicators in an oncology note that the risk is high? And that's a good question to close this activity out with. The risk is going to be specific to each patient and must be assessed by the physician. The AMA added examples to the MDM table for moderate and high risk, but keep in mind they're just examples. So for oncology, maybe you have notes supporting a high level of risk where there is drug therapy requiring intensive monitoring for toxicity. Or another example from CPT is decision regarding hospitalization. But those are just examples of things that might typically be high risk. It's really important that the note is clear on the risk for the patient. CPT gives practitioners really the freedom to use their own clinical judgment to say what the level of risk is. So if the note is not clear, go back to the practitioner and say, what is the risk of morbidity or mortality for this patient? And if they say the risk is high or moderate or whatever the case might be, what are the patient-specific risks to support that risk level assessment based on the treatment decisions made for that encounter? And I know we are at the end of the hour. I want to check in with Leanne. We'll take time for maybe one question, Leanne, if we have anything in the chat.
Ashley, we do not have any unanswered questions in the chat.
All right. I know you've been working hard in that chat, so thank you so much for that, Leanne. So we'll move along. I have just a few reminders before we close out. If you do think of any additional questions, you have 7 days from today to submit those. And you'll send those to our education mailbox, and you'll want to include the title of the webinar, MDM Sunset Session, Reflecting on the Risk Element, or you could just shorten that up to MDM Risk Element or something like that. And that will make sure those emails are sent to Leanne and I. Keep in mind that we are not able to access any claims history, so you will want to contact customer service for any claims related questions. In a few minutes, you will receive an email from me to thank you for attending, and you don't want to delete this one without reading it. The email will contain your certificate of achievement. It'll have your name and contact hours if you need to turn that in for credit towards continuing education units, along with a copy of today's presentation. Now, if you don't receive the email, a couple of things might have happened. First, you may want to check your spam or junk folder. Also, if you joined by phone only, you would not receive the email, as there's not a way for us to capture your email systematically from the attendance record. No need to worry though. If you joined by phone, you are able to email us. Make sure you include the phone number that you joined with, and you can request your certificate of attendance. And Leanne will be placing that email address in the chat. All right. Lastly, please take a few minutes to complete our survey. Tell us what you liked, and you can use this also to suggest topics for future education. You have a few different options to take the survey. You can use the link in the chat, or when you exit today, you will be prompted to go to an external site, and that external site is the CMS Qualtrics survey page. And you'll have a prompt that will look like this picture we have shown here with the little yellow triangle. We included that image on the top right of this slide so that you know this is safe. It's not malware or anything like that. For those that are listening through our website or through YouTube, you will also have the same opportunity to provide feedback. You'll have a survey card at the end of the presentation, or there's a link available in the description if you scroll to the bottom. All right, that does it. That concludes the webinar. On behalf of myself, Leanne, and all of our provider outreach and education team, we thank you for taking the time to join us. We truly appreciate your participation in our activity today. We look forward to your survey feedback and we hope to see you at future events. You may now disconnect. Have a great afternoon.